So now we're going to start talking about exercise prescription for special populations or clinical populations. So I'm going to start with exercise recommendations for those with documented cardiovascular disease, including heart disease, coronary artery disease, and stroke, and then also pulmonary disease. So a little bit of background on coronary artery disease, also known as coronary heart disease. Some statistics here. You can see relatively prevalent in the United States population. Uh, and obviously, the incidence of coronary heart disease get a little bit higher the older that you actually get. So as far as the exercise prescription for coronary patients goes, but they clearly show that the research has shown that exercise is very beneficial for those with coronary heart disease, as far as preventing coronary heart disease and also treating it. And overall, you see the statistics right here: 26% lower risk of cardiovascular related mortality, and 23% lower risk of all-cause hospitalization, 18% lower risk of having a myocardial infarction or heart attack. So, just a little bit about coronary artery disease. Basically, it consists of blockage in the coronary arteries that are supplying the heart. So you have this whole system of coronary arteries that supply oxygenated blood to cardiac muscle that the heart needs to continue to function properly. And due to certain lifestyle factors and even family history, you can get blockage of those coronary arteries, so that restricts the blood flow to the heart, and that can lead to cardiovascular conditions. And probably the most common thing would be a heart attack. So lack of oxygen going to the heart makes the heart tissue start dying, and that's a myocardial infarction or a heart attack. So general recommendations we'll go through in a second, but a lot of the people who have coronary artery disease uh, or they've recently had a heart attack, they're not able to exercise at a very, very high workload. So it's not unusual for them not to work higher than a level of 3 METs, which underscores the importance of getting them into exercise training and becoming more physically active so they can actually improve the intensity that they can work at. And obviously, that's going to improve their quality of life as well. Uh, as far as what to focus on, aerobic exercise is number one. And then also resistance training, weightlifting is recommended for individuals with cardiovascular disease, and also the standard flexibility exercises. Um, a term that you may or may not be familiar with is ischemia. So myocardial ischemia is just lack of blood flow to the heart, and that obviously would be a result of some type of disease in the vessels bringing oxygenated blood to the heart. And the ischemia usually manifests itself by chest pain or what we would call angina. And so, obviously, one of the first signs of heart disease is going to be chest pain. So, you have chest pain, you can detect it on an EKG or electrocardiogram, but simply said, the most common way that you would indicate that someone has heart disease is just chest pain that occurs usually when they exert themselves in some type of fashion. Like I said, resistance training also recommended. However, an important thing to note: resistance training should not be the primary modality of exercise, and only incorporated after someone has been doing exercise for about 2 to 4 weeks, 2 to 4 weeks of aerobic training, and then you can gradually start implementing resistance training as well. So this whole concept of rehabilitation, cardiac rehab is just a process that individuals who have had a heart attack or some type of cardiac procedure, they go to, and it's like a rehabilitation program that they would go through. One of the key components of this rehabilitation is going to be exercise. And so that's what we're going to focus on here. But it includes other stuff like is educating the patient on what they should be doing, not be doing, dietary things, other lifestyle changes that they could make to prevent any cardiovascular events from occurring again. So, goals of this rehab program: limit the deconditioning that's going to occur when someone has some type of coronary process. Usually, they get to that point having a heart attack or some type of coronary event or cardiac event because they're not physically active and they have a poor lifestyle. So you want to limit that and try to offset a lot of the deconditioning that's going on. You want to lower the risk for sudden death or another heart attack. Control the symptoms like chest pain. Exercise is really good at that. The more you exercise, the lower the chances of having chest pain. And also return to work, vocational status, improving that, and also the quality of life. And there are other psychosocial measures to be included. So cardiac rehabilitation is more of a global program that includes exercise as well. So as far as the inpatient recommendations for exercise, so inpatient phase would be while they're still in the hospital. So if someone has a heart attack, they go to the hospital. Sometimes they're there 2 to 5 days, and they can actually begin the rehabilitation while they're still in the hospital. And this is what we would call inpatient recommendations. And so it's important in that inpatient period to determine the risk of another myocardial infarction or any other event. Determine what their tolerance is to exercise, so if they can go home and do things like they would like to do, and then again to educate about the importance of healthy lifestyle and engaging in more and more physical activity. And so what you're seeing down here at the bottom is just who would be a good candidate for inpatient exercise. So no new or recurrent chest pain, stable enzymes. So those enzymes you're seeing, creatine kinase and troponin, those are elevated when someone has a heart attack. So just to make sure those aren't continuing to go up, so the heart's not continuing to be damaged. No indication of any other issues like heart failure or any other abnormal rhythms of the heart. So as far as what's recommended during the inpatient phase, it's actually pretty simple. Frequency is going to be high, 3 to 4 times a day ideally, and it's going to consist of some basic things like a lot of range of motion exercises. So just arm and leg range of motion. That could be even while somebody's lying in bed. Just moving the arms, moving the legs to try to increase blood flow and offset some of that deconditioning. Postural change is great. So just standing up is going to tax the cardiovascular system a little bit, and that's going to cause it to adapt in a positive way. So even just standing up, sitting down multiple times is enough to start getting a minor training effect. Also focus on self-care activities, going to the bathroom, taking care of themselves, moving around the room, etc. And then ideally during the inpatient phase, walking would also be included, and potentially other modalities if available, but walking is a great thing because it's a very common activity that people are going to need to do. So just walking around the room, walking around the hospital, etc., is great for during the inpatient phase. As far as the outpatient phase, once they get out, so cardiac rehabilitation has traditionally been described in phases. So you have phase one, which is the inpatient phase. Phase two is the next phase, the initial outpatient. That would be about 3 months. And then there's traditionally phases 3 and 4, which kind of target like progression and also maintenance. But for trying, just kind of like thinking about the initial outpatient phase, these are the recommendations that ACSM puts forward. And so you can see they're not overly different than what we see for healthy adults. So for aerobic exercise, 3 to 5 days a week, intensity is just going to start a little bit lower. An important number here, though, is involves what's called the ischemic threshold. So the ischemic threshold is the exercise intensity at which someone would start to have chest pain. So if someone's exercising and every time they get to a heart rate of, let's say, 130 beats per minute, they start having chest pain, and that's predictable. So every time they get to that heart rate, they start having chest pain. It's recommended that you stay 10 beats per minute below that. So their ischemic threshold was at a heart rate of 130. They should not exceed 120. And you just apply that. That's a good rule of thumb, no more than 10 beats below the ischemic threshold. As far as time, pretty vague recommendation here, 20 to 60 minutes. Obviously, that could be accomplished in multiple bouts. So initially, maybe a good target would be 20 minutes of activity. It doesn't have to be continuous. Could be 10-minute bouts or 5-minute bouts, even less if necessary, just to accumulate up to about 20 minutes. And then modality, similar stuff that you've seen. Walking is a common one. Other types of exercise, aerobic exercise recommended for cardiac rehabilitation. Uh, a lot of recumbent stuff, just not to tax individuals too much. So recumbent cycling, recumbent stair stepping, etc., even elliptical, uh, but pretty moderate intensity, I would say, is kind of the recommended intensity here. So what they can handle, there's no need to have them go into vigorous intensity at this point. So just accumulate the exercise in the moderate intensity range. For resistance training, you can see it's pretty similar to what we saw for healthy adults. The intensity is going to be on the lower end, 60 to 70%. When around the repetitions, generally a little bit higher. That just is based on the fact that they're probably using less weight and they can do more repetitions. And then 1 to 2 sets is all that's necessary. And same thing, multi-joint and single joint exercises, focusing on the major muscle groups. Flexibility, nothing really different here. Pretty much standard recommendations that as we saw for healthy adults. So again, this should include all components. And so that's it for all I had for coronary artery disease. Stroke is a similar, but obviously this is a different pathophysiology. So stroke, also known as a cerebrovascular accident, is basically when the blood flow to the brain is compromised, and it's similar to a heart attack in the sense that the heart's in the context of a heart attack, the heart's lacking blood flow, so some of it's going to start to die. That's a myocardial infarction. Well, a stroke is kind of the same thing, but with the brain. So lack of blood flow to the brain, and part of the brain tissue actually starts to die. And this is the result usually of blockage in the arteries bringing blood up to the brain, like the carotid. You have the vertebral artery there. And that would be known as an ischemic stroke, which is the most common. This is probably going to be 90% of all strokes are going to be considered ischemic. There's also a possibility of a hemorrhagic stroke where the blood vessels in the brain just start leaking, and or due to high pressure or anything else, and blood leaks into the brain tissue. Some stats about it. So lots of stroke survivors living in the United States, so this is pretty common. Just some pictures showing you the pathophysiology. So in all these pictures, you see some type of blockage that's limiting blood flow up to the brain, and that brain tissue actually begins to start dying. So comorbidities that are common found with stroke include the following. So again, coronary artery disease, hypertension, hyperlipidemia, diabetes, obesity, peripheral vascular disease. All these things are commonly seen in stroke patients, and a couple of things to think about here. One, the etiology of a stroke is very similar to coronary artery disease. So if you have these risk factors or conditions, these are definitely going to lead to the likelihood of having a stroke. So again, like the pathophysiology is very similar. You get blockage in the blood vessels. So a lot of these things like hypertension, hyperlipidemia that can lead to a heart attack, they also increase the risk of stroke. So the comorbidity, it's common to see these conditions in people who have had a stroke. And then also it is also common for people who have a stroke to actually get these conditions after, but due to the lack of physical activity that comes along with having a stroke. So this kind of underscores the importance of exercise training and lifestyle changes in the individuals who have had a stroke. One, it's going to offset some of the deconditioning that would go along with the sedentary lifestyle that generally follows a stroke, and also it prevents the chances of having another stroke. So as far as recommendations for stroke survivors, you can see them here: aerobic, resistance, flexibility. Not that different than what we've seen before. So the one I'm going to point out here is intensity is again not overly different, starting on the lower end. An RPE scale can be used instead of heart rate if necessary. Time, you see the same thing, 20 to 60. Short sessions if necessary. Modality, more so with stroke patients, you're going to see a lot of things that are going to lessen the reliance on balance and coordination. So things like recumbent stepping, like you're seeing in the picture, recumbent cycling, on a treadmill, just because a lot of times the gait is altered in individuals who have had a stroke. Some type of unweighting system, like you're seeing in this picture, might be useful, just to ensure safety and also kind of make it a little bit easier on the individual. Other things to think about: a lot the kind of effects of a stroke are going to be a lot different between different stroke survivors. So a lot of this depends on what part of the brain is affected. So some individuals might be able to walk relatively smoothly. Other individuals may not be, and there'll be a lot of they may need an assistive device like a walker or a cane. But there's a lot of variety in all the symptoms you're going to see in stroke survivors. So you just adapt the exercise modality to fit what they can actually do. Strength training, not that different. Um, again, with resistance training, seeing a little bit lighter weight, more repetitions. Other things to consider with stroke patients. Uh, VO2 might actually be higher at a given workload. So what that reflects is that they're not as efficient. So someone walking on a treadmill is should have a certain oxygen cost associated with that. So they should have a certain oxygen consumption with that. For stroke patients, it's usually going to be higher for that same workload just because they're not as efficient. And their movement economy might be hindered a little bit, especially if they're using some type of assistive device. Like we said, seated recumbent cycling may be preferred if there's balance issues. Avoiding the Valsalva maneuver is usually useful. It takes a little bit straight. You don't want to limit oxygen and blood flow to the brain at all. And then as far as speed of a treadmill, if a treadmill is being used, you can start really, really low. Less than 1 mile an hour is usually appropriate for individuals who have had a stroke. So shifting gears now to pulmonary disease. So we're going to start with what's called chronic obstructive pulmonary disease. And a little bit of background, you can see some basic statistics about it. Two major things fall under the umbrella of chronic obstructive pulmonary disease, and that's chronic bronchitis and emphysema. So I'll talk through those on the next few slides, but major causes of these things: cigarette smoking is number one, or exposure to smoke. Air pollution also plays a role, but those are the big things that result in pulmonary disease. So major symptoms you're going to have: shortness of breath, especially with exertion, a lot of coughing potentially, especially in bronchitis, a lot of sputum production coming out of the lungs. So just a review of the respiratory system: airways. Air comes in, goes down the pharynx, larynx, trachea, and then it's going to go through all these bronchioles, end up at the alveolar sacs. So in chronic obstructive pulmonary disease, there's either going to be a limitation in airflow in these bronchioles or a limitation in the structure of the alveolar sacs. So chronic bronchitis is going to be more the inflammation of the airways, and emphysema is when you start to get destruction of the alveolar sacs. So just some more pictures for you. Chronic bronchitis, diagnosed by, as you can see, cough for 3 consecutive months and 2 years. A lot of this coughing is due to a lot of mucus being produced by the cells in the airway lining. The ducts can become dilated in the mucus glands, secreting, so they secrete more and more mucus, which actually limits the airflow that can actually pass through the airways. So it's going to plug up the airways. They have a hard time getting air through. Some pictures for you. You can see that chronic bronchitis, the airway is inflamed, and also a lot of mucus buildup, and you see how narrow it can get in this picture. With emphysema, you get damage to the alveoli, the air sacs in the lungs, also potentially the bronchioles right before that, and then destruction of the alveoli and other lung tissue. So you can see normal alveolar sacs here, nice and round and relatively small, and then this is emphysema, bigger because a lot of these have broken down and kind of merged, and they end up accumulating a lot of mucus as well. All right, so as far as assessing the severity of the shortness of breath or dyspnea, There's respiratory questionnaires that are commonly used in pulmonary patients. Just ask their perception of how they feel and how they're breathing. But more objective methods of assessing the severity include some pulmonary function tests, which include forced vital capacity, which is measured. It's basically how much air you can forcefully exhale. So you take a deep breath and just blow out as much air as fast as you can, and that volume is measured. The FEV1, or forced expiratory volume in 1 second, is kind of the same thing. It's just how much you can get out in that first second. So if you did an FVC test and blew out as much air as you could also calculate how much air actually came out in the first second, and that is your FEV1. And then what you can do is look at the FEV1 to FVC ratio, and that's going to give you a really good idea of how much air you're getting out quickly. And it should be over 80% in a healthy person. So once that starts dropping, that's indicative of pulmonary disease. And lastly, a test called maximum voluntary ventilation just measures how much air you can forcefully move in and out in 15 seconds, and then you extrapolate it to 1 minute, so you multiply it by 4. So just kind of taxes the respiratory system and sees what the capacity actually is to move air. And you compare these obviously to norms, and then that's kind of how you can base the severity of disease. So treatment for COPD, obviously if they're a smoker, stop smoking. Medications like bronchodilators, which dilate the airways. Steroids for inflammation, possibly supplemental oxygen, which is used in severe cases. And then obviously, hopefully they're engaging in some type of pulmonary rehabilitation, which does include exercise. So as far as the exercise recommendations, you can see not overly different if you look at resistance and flexibility. With aerobic, frequency is going to be very similar. Intensity is going to be similar, but they do recommend using a what's called a dyspnea scale to rate their dyspnea while they're exercising. You can actually use that to rate intensity, and I'll show you that on the upcoming slide. So time-wise, very similar to what we talked about before, 20 to 60 minutes, but obviously that can be accumulated in multiple bouts. And as far as the type, standard stuff, walking, cycling, anything that they can tolerate is generally going to be fine. So other things to consider in COPD patients, higher the intensity, the greater the benefit for the most part. So if they can push to a higher workload, that should be encouraged. So individuals with really, really mild COPD can probably follow just guidelines for healthy older adults, whereas those with more severe COPD should focus on the lower intensity exercise. This is the scale I was talking about. So it's a dyspnea scale, so 0 to 10, and the person just rates subjectively how they're feeling, how their breathing is feeling. So you can see they recommend a range from 3 to 6 on here. So that's anywhere from moderate breathlessness to pretty much severe breathlessness. So once it gets to 7, very severe, that's thought to be a little too high, so they could tone it down a notch. But in other words, it should be taxing them a little bit. They should feel a little short of breath during the exercise bout, and that's fine, and their body will adapt to it over time. So, and just to give you an idea of what this relates to, 3 and 6 on this scale is thought to be related to about 53 to about 80% of their aerobic capacity. So, other things to consider. Pulmonary patients oftentimes get desaturation of oxygen. So you can use something called a pulse oximeter to measure oxygen saturation of the blood. And this could be just a clip on the finger or ear that actually can quickly give you a number to tell you how saturated the blood is with oxygen. In a healthy person, it's going to be around 98% at least. In pulmonary patients, it drops dramatically. It could be less than 90%. And so you want to measure it to make sure there's no O2 saturation or O2 desaturation while they're exercising. So flexibility exercise is important, not only for overall health, but if they improve posture. That could improve the breathing a little bit. Uh, if they use bronchodilators, sometimes it's a good idea to take them before exercise training to make sure there's as much airflow as possible. And then, as far as resistance training, overall, entire body resistance training is recommended, but this is just to kind of highlight not to exclude the upper body, because just strengthening some of the upper body musculature can actually help with your breathing, especially when you get into some of your muscles that you might use a little bit with breathing like your intercostals, scalenes, etc. So other things, back to oxygen saturation. If O2 saturation drops below 88, I think it's the 88% or below, which is pretty low, they should be using supplemental oxygen from a tank. And then during exercise, you should monitor it also to make sure it does not drop below 88%. So you want to sometimes they may be fine at rest, but once they exercise, you get desaturation. So you might have to increase the supplemental oxygen a little bit. So, and some specific things that are very helpful in COPD. Inspiratory muscle training is basically training your respiratory muscles. So one way to do this, which has been shown to be very effective, is inhaling against the resistance. So you just breathe through a spirometer, inhaling, and there's some fixed resistance, so you have to work harder to actually get air in. Just doing that is enough to strengthen the respiratory muscles enough to where it alleviates a lot of the symptoms. So it doesn't have to be intense. So whatever your peak inspiratory pressure is, about 30% of that. So they're working at a pretty low percentage of their inspiratory pressure, but it's for about half an hour a day and most days of the week. So over time, this will strengthen the respiratory muscles like the diaphragm, the external intercostals, and that's going to help with breathing and also reduce the likelihood of becoming breathless during activities of daily living and exercise. And then pursed lips breathing is simply just inhaling through the nose and then exhaling through the mouth. But when you exhale through the mouth, you should kind of use what they call pursed lips, or kind of like a kissing like movement with the lips. So you have a small opening between the lips, and you exhale a lot slower than you inhale. So about 2 times as long. So if you inhale in about a second, exhale for about 2 seconds as long through a small opening in your lips. This has been shown consistently to allow people to gain control over their breathing and reduces the feeling of breathlessness at rest and also during exercise. So moving on to another respiratory condition that's pretty common and not nearly as severe as COPD, asthma. So asthma is just inflammation of the airways, and it tends to come and go. People have asthmatic episodes. But at the end of the day, you're going to get you'll have reduced airflow getting down to the lungs. So you can see in this picture how the size of the airways is actually being reduced during an asthmatic episode. So there's also a condition called exercise-induced bronchoconstriction, which is not truly asthma, but the results are similar, but it tends to only occur during exercise. So some people, when they exercise, they get this inflammation of the airways, and the airways constrict, and that actually is going to lead to breathing issues during exercise. As far as exercise recommendations, very similar to what we see for healthy adults. So again, starting on the lower end, progressing up. Modality is going to be very, very similar. The only thing you will see added here, pool exercises. Exercising in water-based environments is thought to be pretty good for those with breathing conditions like asthma. Resistance training, not overly different than what we see for healthy adults. Flexibility the same way. So other conditions or considerations for those with asthma. There's an acute exacerbation. They shouldn't exercise until the symptoms subside. Bronchodilators, like we said, a good idea to use them before exercise or even after exercise, even in those with exercise-induced bronchoconstriction. And and then those taking, if they are taking corticosteroids for long-term inflammation, those can be associated with muscle atrophy. So it just underscores the importance of engaging in resistance training as well. So a few last things. Cold environments seem to be worse, and obviously, though, in air pollution can play an effect too. So exercising in like a major city where there's a lot of traffic could be problematic for those with asthma. Could trigger exercise-induced bronchoconstriction. Um, and so just consider that as well. So, in regards to the cold environment, sometimes asthmatics will wear something over their mouth, so when the air is actually coming in, it's actually warmed a little bit before it gets in the body. If possible, non-chlorinated pool for aquatic exercise. I don't know how possible that is, but high levels of chlorine can aggravate asthma, so that's the thought there. And then exercise in time of the year, right? With there's certain times of the year where there's an increase in allergens in the air and outside. So that's something to consider potentially exercising indoors in situations like that. And then also different parts of the country, there's different allergens around, so that could play a role as well.